And we're back again. My name is Vince Ainger, and Kathy Craig is here in the studio with us. Kathy is the hospice manager. Welcome, Kathy.
Good morning, Vince.
And I'm going to let you talk first.
Well, good morning. Good morning, Green Spring. Lovely morning. I hear we're going to have some heat coming our way.
Yeah. I can believe it.
But just to let everybody know, the hospice is keeping busy. And I appreciate people coming to us and allowing us to come into their homes and take care of their loved ones. We have really been busy since last week. We've had about 6 admissions. So we are providing a lot of loving care to the residents in this community. So I want to thank the team and everybody that's helping us provide that care. It's wonderful to see in the coordination. It's wonderful seeing the love and dedication that goes into keeping our residents comfortable and providing that quality end-of-life care that they deserve.
I might say Kathy is, for benefit of our new residents, I'm going to ask some questions I should know the answer to, but I don't. But I'm going to say new residents for their benefit.
Yes.
How many patients do you have typically?
Right now we have 17. Census has fluctuated. It's gone down into the single digits, and it's been up as high as 30.
Yeah.
Just depending on the ebb and flow of what's going on campus with the residents' health care.
Sure. And how many staff?
I've got a full-time nurse right now that's out in the field providing the care. I have about 3 PRN nurses. I've got our social workers, and wanted to also let everybody know that the social worker has restarted her grief support group. Sure. It's a good time for family members that are having difficulty. If they feel they need somebody to talk with, definitely give Bonnie a call. She can schedule individual visits or tie you into the grief support group on campus.
Sure, sure. I had something I was going to ask. When my wife was in hospice, the care was superb. I remember hospice came in on a Friday afternoon, Jane, and the stress level just fell. It was palpable. The stress level just fell off. She left the folder with some paperwork inside, and there was a little strip on the cover. It said, "In case of an emergency, call this number first," and that was such a relief to get that, because I had experienced bronchial spasms with my wife previously, and they'd come after dinner, and she'd say, "Oh, I can't breathe. What am I going to do?" And I would eye the pull cord. She hated to go to the hospital, and of course, security comes, and then the rescue guys come, and then it's a hospital stay, and then it's Garden Ridge, and we went through that cycle several times. And
revolving door.
Yeah, sure.
So it's a comfort just knowing that I, as a resident, can stay in my home, and 24 hours a day there's a nurse on call, and she can answer quick questions for family members, or if there's an emergency, she can actually come to the home, evaluate the situation, help the family and the patient put together a new plan of care, whether it's titrating medications, increasing medications, looking at different treatments to manage a symptom. But we can do that in the home setting, so you don't have to pull that pull cord and do that revolving door.
That's right. It was such a relief to have that telephone number. You mentioned that you would like to pick up on something that Justin, our previous guest, Justin, mentioned, having to do with paperwork.
Yeah, Justin brought up a really good point earlier in his discussion about everyone having their paperwork, their living wills, their trusts, their estate planning, having all those documents in place. Because what I'm finding as nurses and staff going in to meet a family for the first time, I like to sit down with my families, not only find out what their goals of care are, but I want to find out what documents they have in place. Do they have that living will that tells their family and tells the healthcare workers how they want their care taken care of as they transition through end of life or through any part of their health care? And One thing I'm finding there's a misconception with is having advanced directives in place versus what's called a do not resuscitate order.
Yes.
When I go in, I'm finding families will say, oh yeah, I've got all of that in place. And then when we go to actually look at the documents, what they thought was a DNR is actually just the living will. And just so everyone knows, the living will is basically my wish list for how I want to be taken care of.
Sure.
It tells my family that in the event that I go to the hospital, how far do I want treatment to go? Do I want feeding tubes? Do I want IV hydration, artificial nutrition? That's kind of my wish list that I want my family to adhere to, and if I can't speak for myself, I want them to say, no, this is what mom really wants. Versus a do not resuscitate order is an actual order that comes from a physician. It's a one-page document that basically states, in the event my heart stops or I stop breathing, I don't want CPR or cardiopulmonary resuscitation done. Let nature take its course and just let me die peacefully.
Yes.
So I just want to remind everybody that as you're looking at your documents, to take a look at not only your advanced directives, your living wills, your trusts, and your estate planning, but take a look for that do not resuscitate, because if that is something that you really truly want in place, you can work through the doctor first at the medical center to get that document put in place, or talk with your community social workers, because they can also help engage that discussion and facilitate getting that paperwork completed. Because again, when we go in, we want to make sure that we're adhering to the patient's wishes. They're kind of our boss.
Yeah.
And they let us know how they want to be taken care of, and we want to honor their wishes, because that relieves the stress level too.
Oh, yeah. As I remember, for some reason, as I recall, when at the end of Mary Ann's life, my wife's Mary Ann's life, the DNR could get kind of technical, as I remember it. And I remember talking with the doctor in the hospital, and basically what I said is no heroics. And I hope that they would put some interpretation on that would be agreeable to me and to Mary Ann. All right, so
when we go in as the healthcare worker, as you say no heroics, then I'm going to be the one sitting down saying, okay, when you say no heroics, how far are we going? Are we just doing basic comfort and symptom management? Do you want that feeding tube in case you can no longer swallow? Do you want artificial hydration or nutrition? Because again, you're the boss, and we want to adhere to the goals of how you see your care happening. We want to relieve your stress. We want to give you whatever quality of life that we can for the days somebody has.
Sure. This is all very good stuff. Now, how do you decide when a patient should go into hospice in the first place? How is that decision made?
Well, a lot of times a family or the patient themselves will call us up and say, you know, I've been having these declines, I'm not feeling good. Can you come and evaluate what's going on?
Sure.
So we can go without a physician's order and talk with somebody, share what the benefit entails, which then opens up that broader discussion about how they want their care rendered. And then from there, if somebody looks like they're meeting the criteria, because there's different criteria for different disease sets, and we're looking to see if they tack off basically on the different criteria. Is there weight loss, major weight loss? Are they having continuous infections? They're no longer going back to baseline where they were. Is there functional deficits? Can they no longer manage care for themselves? Respiratory issues, is there oxygen? Is there symptoms going on that will not be reversible?
Yeah.
And symptoms where it's looking like somebody's life expectancy is measured more in months instead of years. And from there, then we can have a discussion with the doctor to say, hey, this is what's going on. This person has asked for an evaluation. This is what we're assessing. Do you feel that they're hospice appropriate at this point in time?
Yes.
And the doctor helps guide us into making those decisions.
Sure.
Or referrals can generate straight from the doctors, straight from the social workers in the community. And then again, we just start that process of exploring with the patient and the family, what are your wishes for care? How do you want your care rendered? Why are you feeling like you're looking toward hospice at this point in time? And then opening up to that discussion with the doctor, getting orders, and starting the services.
Sure, sure. I can remember at one point when Mary Ann was in hospice, I wanted to ask the nurse, how long do you think Mary Ann has? And I didn't want to ask that question. And eventually I did. I didn't think that she would know the answer to that. And they have a pretty good sense of just how long.
We've been doing this so long
Yeah.
that you do get a sense. Yes, there are surprises that happen.
Yep.
People will go to sleep, not wake up.
Sure.
But as symptoms change and we're looking at different things that happen at end of life, whether it's no longer eating and drinking like they were, more bedbound, maybe there's more mental status changes, or somebody's just withdrawing mentally from life going on around them. There's a sense that we can get that, life expectancy is more limited to days, weeks.
Yeah. I remember Jane leaving the apartment on a Friday afternoon, and she said to me, "You may not get through the weekend." And so she said, "Now, you remember what you do?" And of course, yes, I did. Called when and Mary Ann passed on a Saturday, early Saturday evening. And I didn't know what to do. And the hospice nurse who was on call at the time came in from, I think, Manassas. But she was marvelous. She just handled everything for, did an examination and worked on the paperwork. I think prepares the death certificate probably.
Not prepare the death certificate, but coordinate with the funeral home. She'll call the funeral home to come out, give them the basic information, let the family know what to expect next once their loved one passes.
Sure.
Again, it's such an emotional time, so whatever stress relief we can give to a family and help them get things in place, then we're not working in crisis mode at the end, trying to make those decisions that if we make them early on, then all you have to do is worry about and enjoy living.
Yep.
And enjoy your moments that you have together.
It was a big relief for me, and one of the things that still kind of haunts me a little bit is why was it such a big relief? Because Mary Ann's quality of life was so bad, or because mine was so bad? And it was probably some mix.
And it's not bad to feel that, because a lot of people come up and say, well, gee, I feel guilty because, I'm happy mom's gone, or my loved one, my wife is gone. I think the happiness comes in understanding that they're no longer suffering. Yes, you miss them.
Sure.
You miss them dearly. You miss what you had, the memories. But just knowing that they're no longer suffering, and then whatever faith system you bring to the table as a family helps strengthen you and get you through your days.
Yeah, sure. Kathy, we're coming to the end here, and I'm so glad that I thank you for coming in. And